Thank you, Chris. What a thought-provoking start to the summit. I've got a wonderful panel now to take the conversation a bit further. The discussion is not just about the information environment in which all of the things that Chris was talking about land. It's also about the people it lands with and our beliefs and how we go about interacting with information, how we're feeling about institutions, how identity shapes health information, and what that means for health and healthcare. So to help me talk this through, I'm going to introduce my wonderful panel. So we've got Mark Henderson, who is the Executive Director of Corporate and Engagement at Wellcome. Wellcome probably needs no introduction, but it is one of the 3 largest charitable funders of science. Mark has been there since 2012, leading Wellcome's work across all communications, in charge of the Wellcome collection, which many of you may have been to, and is leading the work with More in Common that we're going to be talking about today. Mark, before he went to the Wellcome, was science editor at the Times and has written 2 books, including the Geek Manifesto, which looked at the relationship between evidence and politics back in, I think, 2012?
2012.
Yeah.
Long time ago now.
Long time
Different
ago.
World.
We've got here Samira Ben Omar, Summit regulars. Will need no introduction to Samira. 25 years or more, I think, working in and around the NHS, founded the Community Champions programme in Northwest London, has worked closely with the Grenfell community to facilitate local conversations and amplify their voices. Samira also led community engagement during COVID. She contributes to the London South Bank University and is also a Nuffield Trust trustee. So welcome to Samira. And then Dr. Deborah Cohen, who I'm going to call Deb. I hope that's okay.
That's all right.
A medically qualified award-winning journalist, broadcaster, writer and editor. Back in the day, established the investigations unit at the BMJ, led health coverage for Newsnight during COVID, so you may have seen her on your screens. After that was ITV health correspondent, is now a published author, Bad Influence, which actually I've got a copy of over there, came out in January looking at the commodification of health in an age of anxiety. Is also a visiting senior fellow at LSE Health. So, but before I bring the panel in, I want to show you something. So this is where you get to see the results of our quiz, but not quite yet. I'm just going to talk to you a bit about it. So thank you for completing the quiz. I understand that the one group that needed prompting to actually fill it in were Nuffield Trust trustees, so we'll be taking that up with you later. Thank you to More in Common for giving us access to the tool and for Wellcome for making the introduction. So More in Common work to understand how the public's beliefs and values shape their approach to major issues. They've been working with Wellcome to explore attitudes to science and scientists, and the research segments the public into 7 groups, values-based groups, but based on underlying beliefs. You'll be pleased to hear, I'm not going to read these all out to you. There are sheets on your tables which show you what these groups feel and think about different issues, but you'll see the 7 segments there. These are based on underlying beliefs. They look at values and not demographics, and they explore how people relate to authority and institutions. What I'm going to show you now is this room and how it compares to Britain. So you will see, perhaps unsurprisingly for the Nuffield Trust Summit, that this audience sits in segments that are largely comfortable with institutions and experts. You might not be surprised to hear that nationally you're not in the majority. Large parts of the population are more sceptical, or they feel that systems don't work for them. And you'll see on the next slide where we, in yellow, compare to society as a whole. I'll just let you have a quick look at that. So if we're going to talk about polarisation and trust, we need to be honest about where we are positioned, where experts are positioned compared to wider beliefs, and perhaps understanding this and unpicking it a little bit more will help us understand and think more deeply about what Chris challenged us with this morning in that talk. So, oh, no, they're not. Great. So, Mark, I'm going to come to you first. Sure. So what does the gap between this room and the wider population mean for scientists and for science and healthcare institutions, really?
So I think it's fascinating, and we suspected that this might be so. which is one of the reasons why we kicked off the research that we're doing with More in Common at the moment. That will be published next month in April, and I strongly encourage you to look at it when it does. It's got some really fascinating themes. I'll talk about some of them a little bit today, but I think it's actually one of the most significant challenges that we face in public health and science in the UK is the difference in broadly shared values between the professional and managerial groups who actually do most science, provide most healthcare, and the wider, broader population who, as Chris was saying earlier, are actually largely pretty trusting and largely want to do the right thing, but do not always necessarily trust a group of practitioners and experts who they feel do not necessarily always share their values. And I think the data that we've shown in this room, it's very typical of the sector. If you read More in Common's report, particularly on the progressive activist segment, which I did a couple of years ago, the sort of distributions we have here are normal in the charity sector, in the public sector, in lots of parts of elite institutions, you might say. And some of that's natural, some of that comes from demographics, from education. The first step we need to be aware of to counter it is that it's there. If we don't know it's there, there's very, very little we can do about it. I think it's particularly interesting, though, because the progressive activists in the More in Common work are really particularly unusual compared to the other groups, because we're not in the UK generally very like the US. In the US, beliefs and values really tend to stack. If somebody's a Republican, you can really predict their views on virtually everything. Same if they're a Democrat. Actually, for most of the 7 segments in the UK, that's not true. The one exception is the progressive activists. The progressive activists tend to have what you might call a sort of set menu of beliefs and values, that many of which are highly altruistic and commendable values, but they do tend to go together. I think the concern is if belief in science, value of science, respect for the scientific method, commitment to public health becomes part of that set menu, the risk is it is rejected by people who don't like other bits of the set menu. And I think that's where the real risk here lies.
So presumably you weren't very surprised by the result we saw?
Not at all. And when we've done this in groups in Wellcome or in science, we've had similar results. So it's not unusual. There's nothing to be ashamed of. But
so I think this may be the 18th Nuffield Trust Summit. If we'd done this 20 years ago, would we have had the same? Have these divisions always existed?
Hard to say because we don't have the data. My hunch would be that it would look different. I think certainly anecdotally, I would say that the support for science and public health across the political spectrum was probably higher historically than it is now. Certainly in the 80s and 90s, you had, certainly if you look at the US, different obviously, but science spending generally went up under Republican regimes. So I think it would probably look different, but we don't necessarily have the data to show that. What we do know, I mean, Chris is absolutely right that trust in science has increased over the 20-year horizon. Actually, over the more recent horizon, it has dipped. It's still very high. I mean, in the More in Common research, that we've done, it stands at 84% have at least some trust in science, which is great. The Wellcome Global Monitor will be publishing a number of those in the autumn. Again, shows that it's high. But what worries me more is that you've got some leading indicators of distrust that are sort of bubbling away there under the surface. Do I find scientists relatable? Are they people like me? Do they share my values? Does science actually benefit my community? Those are sort of and the other thing, again, as Chris said, the trust can be very high in the abstract, but actually when you get into the sort of nub of a particular issue, it can actually break down quite fast.
Great, thank you. Samira, I want to bring you in. So from your experience working with communities, what actually builds trust in health services?
Well, I suppose just going back to the to the different segments, it's not surprising at all, but also kind of from the perspective of grassroots communities that actually kind of really reflects the reality. The issue and the challenge is that how connected are we to that reality, and how are we proactive in knowing and understanding how we see things and how what we value is probably disconnected from the reality of people's lives. So in terms of trust, I mean, in the very early days of COVID, when lockdown happened, some of the national narratives, some national messaging around the do not share bathrooms, self-isolate. We knew, working with people and communities, that was completely disconnected from the reality of people's lives, because people were living in overcrowded accommodations, people were living in multi-generational, multi-occupational households. So how can you do that? And one of the things was actually how the community, this is kind of more the civic action, how the community came together to really connect differently with communities and to sense check how you're feeling, how you're coping, how you're making sense of this. So I think trust is about actually kind of working through the people and the organizations who have the trust and the connections and the networks. And I think sometimes it's not just about knowing and understanding that there's a gap, it's being mindful of it and actually kind of acting and stepping into that in-between space to really kind of connect differently with people and communities. Trust, I mean, even during COVID, trust really kind of began to generate when we had people of those people and communities, as Chris said, people from the Somali community, people from the South Asian communities who came together with, Bob can tell you, we actually kind of brought together clinicians, local clinicians, experts and community leaders together to really kind of think through how we connect differently with communities, what are the key issues, how do we promote trust. So for me, the trust is not about actually kind of, it's not an idea, it's an approach, a way of connecting differently with communities around the conversations that matter to them. There's the issue that it doesn't happen in a vacuum. It's not about actually kind of having a trust in a vacuum. There's a whole host of other things that impact on people's health. One of the challenges that we had in the conversation, difficult conversations around COVID, was very much, well, there's a whole host of other things that matter to me that are really priorities for me. If schools shut down, I already live in overcrowded accommodation. How am I going to cope? What is the impact on my mental health and well-being? If my kids can't play outside, they have nowhere to play. So those realities and those issues actually had an impact on actually kind of what decisions people made.
And when we've spoken about this before, you've kind of highlighted that it cuts both ways. So we talk a lot about declining trust in institutions, but I think you were also making the point that people are not feeling like they are trusted.
Well, I mean, it's both on a one-to-one in clinical interactions, but also kind of between institutions and communities. I trust you when you trust me. I listen to you when you listen to me. And there's a lot of communities whose voices are completely dismissed when it comes to kind of where the power dynamics are. We want communities and people to trust us, but we don't trust them enough to actually have an honest and transparent conversations about what are the negotiables and non-negotiables. So when we look at engagement across health and care, often it's quite performative. I'm going to go out, I frame the question, I frame the challenge, and I tell you what are the key things, the few things that we want to engage with. And that actually kind of creates a certain level of not just exhaustion, but that's where the moral injury is not just about people being exhausted, it's also about the fact that their voices are not heard. So I think it cuts both ways. When we start to trust people and communities to know and understand that if the challenges exist in those groups and communities, that the solutions must lie there, then that gives us permission to really actually kind of act on it. Then it kind of works both ways.
So I think it's a good time to bring you in, Deb, because of all the work you've been doing looking at the social media influencer environment. In this kind of in a vacuum of information often, why are outsider voices so effective? I mean, I think that's what a lot of your book picks up on, the power that an outsider voice will have to really get that trust from their communities.
Absolutely. It's building on what Samira said. It's about being heard.
Yeah.
It's about being validated, having your concerns validated and not feeling dismissed. And one of the issues is that repeatedly, and obviously these are a series of stories that I did, so it's a lot of sort of probably selection bias about some of the people I interviewed, but I interviewed about 200 in the course of the book, and that included influencers, marketing agencies, clinicians, and academics, and repeatedly the same stories. We're not feeling heard. There's a community online that validate our concerns, and that sort of came up particularly as well in young women around their contraceptive choices, and perhaps they couldn't have the conversations they wanted to with their clinicians, so they go online, and then they're targeted by all sorts of commercial actors. So one of the things I was interested in is the commercial determinants of health. What happens when you put health on platforms that are ultimately geared for entertainment and sales? And so that's when perhaps they're exploited and led down different pathways. But it does come back to feeling heard, feeling seen and validated. And what influencers do is they develop what you call parasocial relationships. So they make you feel like they are like you. You know, you'll see them lipstick on, giving advice behind the wheel. You'll see the sort of toddlers, the messy kitchens. But obviously they're only showing you what they want you to see, and we know they don't always declare their conflicts of interest or their commercial incentives. And then how they behave is they respond to the comments that come under any sort of reel on Instagram, or they'll drop into your DMs, and that is the current currency in the commercial sector, is to drop into your direct messages to continue the conversation there. And obviously that's very hard to regulate if you are talking about, you know, let's say one of the GLP-1 weight loss drugs. But they build this sense of knowing you. And then where I think it becomes more troubling is when, and I've seen this online with doctors, is where they lean into the parasocial relationship. So they make believe like they're you, but then they lean on authority bias. So I'm an insider, but I'm outsider. I built up this relationship with you. I'm an authority, and then I'm going to sell you my dodgy wearable device that might go on your arm. So I won't name which one I'm talking about, but I think you can probably imagine. And then they use, and this is where the misinformation space comes in, they'll use their own, it's the hero's journey, their own anecdotes before the trial evidence is available that perhaps shows benefit or not, as the case may be. So it's very, very difficult for people to navigate this space.
Yeah, so interesting. So, Mark, I think one of the things that it's really clear is that to talk about evidence and fact often requires caution, caveats, being honest when things aren't clear, as Chris has said this morning. Is there a danger that that experts who are trying to do that end up ceding ground to ideas and even harmful points of view because you have this sort of grey area? Well, it's not very clear. How do you think that scientists and experts can navigate that by being clear, as Chris said, about what we don't know, but also perhaps not allowing that kind of uncertainty to mean that we end up with information that can be very difficult? I think that's a real challenge.
It's a great question, and the answer, the really simple answer is yes. I mean, it is harder. It is harder for those of us who really value evidence, for all the reasons Chris said in his talk. There are argumentative and advocacy tools that are available to others that are not available to us, and some of them are very effective. So we just have to accept that. I think what we absolutely must do is always acknowledge the uncertainty and never overclaim. And because, as Chris said again, as soon as you fall into the traps of not doing that, you're lost. You have lost all credibility and authority, and you can be presented as the epistemological equivalent of your adversary on this. You shouldn't think of them as adversaries for a start, but that's the first challenge. I think the second thing, and this actually is coming out very strongly of another piece of work we're doing at Wellcome, where we've had Rand look at the evidence base for trust in science for us to inform our future work, and we will be doing a lot more work in this space. But one of the challenges here is actually then when science and public health do encounter politics, which is inevitable, because you cannot make progress on these issues without doing that. But how you do it is fraught with risk, but there is a way through. It's fraught with risk because, again, our More in Common research shows very strongly, and this will not surprise you, that particularly among certain groups who distrust institutions, the closer that science becomes associated with politics, the more the distrust grows. Now, that happens in two ways. It happens because of the general distrust of politics and government, and there is a crisis in that, as we all know, but also because among those who sort of see science, public health being dominated by the progressive activists, do feel that science has a left-leaning agenda, and in our study it shows that feeling is much higher among the more right-leaning segments. If people do feel that science is too political, they are twice more likely to think it has a left-leaning bias than a right-leaning bias. This is probably not surprising, but it's interesting data. But what we need to do in this is be really clear about what's actually informed by evidence and what's informed by values and other factors that are part of politics that are not evidence. What science and public health can do really well is to define the opportunity space, the options, the risks, the consequences. It cannot, building what you were saying, Samira, it cannot decide how to weight those factors against other factors that may loom much larger in people's lives. So we should be, a word that keeps coming up in our research is agency. We should be giving democratic agency to the people who are actually elected to make decisions. We inform them.
Yeah.
And we should be giving people agency, as you were talking about.
You've spoken about this before. Do you want to say a bit about your thinking?
Absolutely. I mean, this is one of the key things is, and one of the challenges and frustrations in working with grassroots communities is that sometimes we package information and evidence as absolute.
Yeah.
And then it becomes almost a little bit of a parent-child conversation, rather than actually, this is what we know, we're given the best evidence for now, but nothing is absolute. This is what we know. And then our role is not to convince people about one decision or another. Our role is to actually give people the information so that they can make informed choices, because we don't know the reality of people's lives and how they live their life. So the taking away of agency and being mindful that actually a lot of the lives of people are actually kind of where they don't have a sense of agency. They don't get to decide where they live. They don't get to decide what benefits they're on. They don't get to decide a lot of things, because those things they have no choice in. So when we actually have this thing where people have a choice and agency to act, we need to be we need to have the humility to really sit with them and actually kind of give them the information so that they can make informed choices. But also to be mindful that actually if they decide otherwise, we have to respect that as a community. I mean, one of the key things that came during COVID, the conversations, was COVID affects me, but it affects you equally. Therefore, the system knows how to come together and rally itself when it also affects you. So, you know, us as progressive activists, when it affects us, then there's a whole mobilization. But then when grassroots communities are affected, where there are higher prevalence of long-term conditions, issue around overcrowding, then actually kind of the system is not so mobilized. So I think we need to have we need to create those spaces to have those uncomfortable conversations that actually health and well-being and vaccines and trust don't happen outside of all the wider social elements that happen in communities.
So I think we're hearing about a kind of quite paternalistic way in which science and evidence and information about healthcare has perhaps fallen short, and understanding better how communities can engage and how the conversation can go two ways. Deb, obviously you were and are a traditional journalist in many senses, working in traditional sort of what's sometimes called mainstream media, but you've also delved right into the influencer space. What are the lessons there for journalists, people reporting on science, healthcare, to kind of how can they play into this conversation, and particularly given that what we're kind of, I feel like we've got a paternalistic situation that we kind of know isn't working, communities saying what works for them, perhaps not not being listened to all the time, and then a media that is increasingly less influential in some ways, and a sort of social media environment behind that. How do we cut through all of that?
It's really, really hard, and it's very, very messy. I mean, you go to all different sort of places for different information. You don't necessarily know, and this is one of the challenges about changing behaviour, is you don't necessarily know which bit of information has tipped you over. So when people are looking at sort of longitudinal studies with social media, is it that influencer that ultimately has changed that behaviour when you are surrounded by all sorts of different, your friends, the TV, family, you don't necessarily know that, and that's quite tricky. I mean, the thing I think, and again, I think, talking about polarisation, the two of the most polarised subjects that I've reported on, COVID, and also gender, for Newsnight, and I was reporting on that, on the science of that, before the CAS report. And a lot of it's about listening. What are the questions? People might vocalise their views, but ultimately, what's the question that they're trying to answer? What's the question they're trying to ask? And just listen as much as you can to what people are saying. I don't really use the term misinformation. I don't know how to apply it in a journalistic context. But and again, I think we have to be careful in the language we use and being paternalistic and dismissive. And I think one of the challenges I've seen is there's a whole movement around slapping people down around misinformation. Sometimes that's justified, and I think absolutely, as Professor Whitty said, going for those commercial incentives, those commercial actors, which is why I set up the investigations unit at the BMJ, is scrutinising those commercial actors. But sometimes people just are confused and they don't know what the right information is, or sometimes the right question hasn't even been asked by science, or the right statistical analysis hasn't been done, or the right randomised control trial, or so on and so forth. And where we saw that in the book, I saw that was problematic, again, going back to contraception. It was a whole movement, and you can either pejoratively call it hormonophobia or hormone hesitancy, where young women coming off the contraceptive pill, is they were turned to social media and said they gained weight, and there isn't randomised control trial evidence to support that, but there might be all sorts of other reasons at that time why they're sort of gaining weight, but they were dismissed by health professionals as spreading misinformation. They already feel alienated by the health service. Well, this is also already a
scientific community that hasn't necessarily invested in research in women's health.
And women's health. But by dismissing them and saying you're spreading misinformation, they're not going to come back into the health service and go, well, do you know what? You're right. And feel welcome back into the health service. So a lot of it is about empathy, and it sounds trite, but a lot of it is about empathy, listening and understanding.
Great. I'm going to come into the audience soon, but before I do, I just want to talk, we've talked about the information environment, we've talked about institutions, I want to talk about the people that work within those institutions and the people that use them, because it doesn't just affect public attitudes, it affects scientists working in institutions, it affects frontline staff delivering care, managers running and planning services. The NHS and social care depend heavily on international staff. We know that one of the most polarised issues is immigration. The narratives will get amplified around immigration, people feeling that economic frustrations will get blamed on migrants. Is that something that comes up in the more in common work you've done around science and scientists in terms of what it's like to be perhaps an immigrant worker in science?
It isn't something we've looked at, and it's not part of the frame for more in common, beyond the fact that there are some questions in the segmentation itself that looks at sort of underlying attitudes of that sort.
Yeah.
I think that the key to thinking this through, though, is it's the same basic principles as everything else we've been talking about. It's about empathy, it's about listening, it's about recognising that this doesn't have to be a stacked belief, doesn't have to be...
What do you mean by a stacked belief? A stacked belief
where you have a whole set of beliefs and political and value propositions that all go together. And if you believe one, you feel almost socially obligated to believe all the others as well, which is a particularly common thread among the progressive activists, okay. Less common among the others. But I think I'm probably less qualified than someone like Samira to talk about this on the front line. So.
Yeah.
I think there's two things. One, it's just from anecdotes and the impact. I think there is something about talking about the idea of immigration. It is a proxy for a whole host of other things. Right. So the conversation around immigration affects not just the international work, it affects racialized and minoritized communities, and we have to be honest that actually sometimes it is a proxy for racism that exists within. If you look at our, whether it's the annual staff surveys that the NHS does, or the patient experience surveys, you will see there's a correlation between, it's up. If you look at the numbers of people from Black and Asian minority communities experiencing racism and discrimination is huge compared to their white counterparts. So I think the immigration issue and the challenge around actually the workforce is not just about whether we need to have or whether we need international workers. The NHS is built historically. The NHS cannot function and has been built off the back of immigrants from the very first day. So I think it's not something that we can do. I think the stories that I hear is about the impact of everyday life, the impact of people being assaulted, the impact of being racially harassed on the ground. So I don't think we can talk about the idea of immigration and international workforce without actually kind of rooting it in how that those ideas and those conversations manifest themselves in people's daily realities.
And do you think that institutions and those closest to power, privilege, have a responsibility to be challenging some of those attitudes? How do they, and if so, how do they go about that?
Oh, absolutely. I mean, it is our kind of duty. It is our duty, whether it's kind of our legal duty. We have a duty of care, under the Equality Act, and the duty to look after our own workforce. I think one of the challenges is that sometimes the experience is that a lot of institutions do hide behind policies and strategies and plans, and there's something about actually kind of a disconnect between just a human connection when sometimes there are tensions happening. To what extent do we need to step into the comfort of just be compassionate towards our frontline staff, acknowledge and understand that actually they are dealing with a lot of tensions, and a simple, how you coping, how you feeling, actually is kind of, that speaks volume as opposed to a policy. I think for me there's something about how we address the reality of year on year. Staff surveys show that discrimination is persistent and it's disproportionate. And
Deb, in your work, are you seeing that there are some voices that are retreating from public debate because of the kind of polarisation that we're talking about? And does it mean that people are not willing to speak publicly, that we might actually benefit from hearing from?
Absolutely. I mean, it's toxic. I mean, it's incredibly toxic. And I was speaking to someone only a couple of days ago who's retreated, particularly on the social media platforms. I mean, X now, quite frankly, is a cesspit. It was always polarised, but now it's sort of, it's barely usable. Even as a journalist now, I used to find it a great source for stories, particularly during COVID, where there would be people, let's say, in UK HSA that I wanted to interview, but they weren't allowed to. They weren't able to speak to me on the record, but they would put out amazing threads.
Yeah, I remember them.
Twitter, I think it was then. Yeah. And that really helped shape my reporting. I could refer to it, even though I couldn't.
And that's not being replaced by anything.
No, I mean, and Blue Sky just isn't the same. It's a bit sort of chin strokey. But you want, but again, you get a certain voice there. What was you did get polarity in some way. So you heard. So it's good and bad. I mean, one of the challenges is when you work on a programme like Newsnight, and I was sometimes uncomfortable with this, is you want things to spark in the studio. So you get a disco, and so you get polarised and
discussions like this.
And actually science is more uncertain and more nuanced. So I think that can be really challenging. when I was reporting, it was always, I had the mantra in my head: benefits, harms, uncertainties, cost effectiveness, opportunity cost. What's the level of evidence, kind of constantly going around my head. So you try and bring that nuance into reporting, but then when you want it to spark afterwards, but it is incredibly polarised. I mean, I don't really use it anymore. I mean, I've had all sorts of things, death threats and you name it. GMC referrals, so I'm not on the register. I hasten to add, there's a reason for that. All those kinds of, and people are retreating.
Yeah, they are. Okay, fantastic. Thank you so much. I'm going to bring it out to the audience now. So we've seen where we sit on segmentation. What are we missing? I can see a hand up in the middle here. I might take a couple at a time if we've got a lot of hands up, actually. So I'll go, in the middle, and then Becky, I'll go straight to the next table as well after that.
Thank you. Fiona Fox from the Science Media Centre. I found this morning so refreshing, absolutely fascinating. And I think I've been saying for quite a long time that when you dig into what the public think about scientists and why they have this 80% trust level, it is things like their subject expertise, their willingness to put aside their biases to look for the truth, their objectivity and impartiality. So all the things that you were talking about, Mark, is, I think, why they're trusted, and we risk undermining that trust if they become more political. But my question to you all, but maybe Mark in particular, given that you're doing this work, is how do we have this discussion with the progressive activists? Was that what they would call the... I tried this recently with a room of public health students, and I have to say it went down like a cup of cold sick. They absolutely hated me. They think they were brilliant, they were wonderful people, they were put on this earth to tackle health inequalities and social inequalities and call out this stuff, and they were basically accusing me of pandering to Trump and Farage and their supporters, rather than, as one of them said, we need to go to war with these people. So how do you, given the risk of losing the trust of Trump and Farage supporters in public health, which we really need right now, how do you have that discussion with them?
Okay, and I'm going to bring in another question just so we can get through a few. So we've got one straight ahead while you think about your answers to that one.
Hi, Ruxana Kapasi from Bernardo's. In terms of our relationship with communities and the public, and the proliferation of social media in particular, those that experience the most inequalities are the most vulnerable in terms of having least access to healthcare and being more vulnerable to disinformation and polarisation debates. I'm really interested in the panel's views on what they think the future of healthcare organisations should be in this space of social media and AI, and how we can step into this space effectively.
Okay, so question from Fiona about how to actually take this conversation. Do you want to start, Mark?
I wish I knew the answer. I agree, Fiona. It's a huge challenge. I guess two thoughts. The first one is, again, I think the same principles apply. You have to think, well, actually, why do progressive activists believe what they believe, and listen to them as well. And think, actually, what are the motivations, what are the reasons why perhaps the progressive activist community may in some ways be actually more intolerant than some of the other segments. But then think, well, what would resonate with them? And actually the robust adversarial, hang on, you're wrong, isn't going to work. It's not going to work with anyone. When's the last time you changed your mind about anything because somebody challenged you and said you're wrong, and probably you're also a bad person, by the way? That doesn't work. So I think the first thing you need to do in this situation is present the data as to how unrepresentative those views and values actually are.
Well,
doesn't mean they're wrong.
We've done that today.
Doesn't mean they're wrong. but that realization. Because again, I think another Archie, who's at the back from More in Common, would I think confirm this. One of the other things about progressive activists is they tend to think that their views are far more widespread in the general population than they actually are. Yeah. So that is one of the first things. But then the second thing I'd say is to ask back, well, how's it going? How's this sort of strong sort of social justice activism going in the world at the moment? Is it leading to more injustice? Is it leading to less polarisation? Is it leading to a more equal society? I think the jury's out on that one, to put it mildly. And so I think the real way into this is about, actually, if you really want those outcomes, what's actually going to be most effective at bringing along people who do not agree with you? Because you're not going to do it by carrying only the 12% of the population who actually agree with that agenda axiomatically.
Okay. Do you want to take the second question, Deb, or do you want to come into that? You can do both if you want, but I thought the second one was interesting because it also talked about AI and the social media environment for organisations. We haven't spoken about AI at all. You're going to have to do an update to your book, aren't you?
Well, actually, funnily enough, I'm actually doing a PhD by publication on those very questions. That is the current plan, to think about how this is going to shape our relationship with the health service, doctor-patient relationships, large language models, and how that is going to, what communication looks like in that environment, what that does to trust, how you respond to those sorts of questions and queries. If the bot says, this is your diagnosis, with all the bits at the bottom, this isn't a diagnosis, but it's delivered as it is a diagnosis, and what that does, if a doctor comes up with a different sort of clinical judgment, how you navigate those situations. And I think they're going to be the things going forward that we're navigating already, and again anecdotally, and Michael Marmot said to me quite a while ago that one of the problems with academia is it's always slightly behind the commercial sector, because you've got to go and get your funding, your ethical approval, get peer reviewed, published. I often look at what the PR agencies are saying, stuff like that, because they can go out and do market research in a heartbeat. But already, anecdotally, you speak to doctors, and I know there are plenty here, where they are having to navigate information constantly that has come from social media. And it is a different information environment than your classic, here's your cuttings from a newspaper, they're the headlines, because you have this parasocial relationship going on, this convincing sort of relationship, and people are spending a lot of time on these platforms. One OBGYN at Duke University, which is in North Carolina, said to me, and she's in a red state where the abortion limit is dropping, she said her patients wait a year to come and see her, they're spending 4 hours a day on TikTok. Now, how do you deal with that information? The first half of her session is dealt with dealing with that information. So it's how we respond to it, I think, is the question going forward, particularly with the growth of the likes of ChatGPT and Claude and Perplexity and so on and so forth. And
Samira, do you have any advice for Fiona talking to young scientists who say they want to go to war against some of these ideas, from the work you've done listening to communities and actually amplifying some of their voices? So
I suppose one of the things is about where people from diverse views and perspectives come together, and I think there is something about the communal space, the community space where people come together, and I think the challenge at the moment is there's a polarization. I'm going to go to the people who think like me, who have the same views, who have the same ideas, whether it's kind of a faith group or a community group. And I think there is something about the if you like, the civic space. So one of the challenges for a lot of community and voluntary organizations and grassroots groups is there's an erosion of community space. So a lot of the community spaces, the libraries, have closed down. So people who traditionally would have come together around those spaces, those kind of don't exist in the same way. So then how do we begin to actually kind of think about, this is where the role of health and care organizations as conveners of some of those spaces to really kind of begin to think through. Because the problem is we have a lot of assumptions about why people are angry about certain things or why people have particular views. What we don't do is actually kind of sit enough with people to actually kind of really listen, not just to respond, but listen to truly understand what is going on, what is happening, and really bring people together around some of the issues. I think in terms of polarization, people don't, I remember we used to do a lot of work around community cohesion. And community cohesion is just an idea. Who connects to community cohesion? But then if you say, you know, I have a real issue about child oral health, and you have the same issue as a parent, we can come together around that. And that's how people from different backgrounds, different communities come together around a shared issue and a shared principle. I think at the moment what we try to do is actually kind of think through ideas. But what we're not thinking is how do we make those ideas actually truly connect to the daily reality of people's lives. So if we want to think about health and care, and we really want to think about actually kind of polarisation, we really need to think is, what do people come together on? What matters to local people at grassroots level, and how we can bring them together despite of their other views, because there will be some views that they come together on. And hopefully for me, I mean, that's the optimist in me, that's what actually kind of connects. If I know you and you know me, I'm much more likely to connect to you and actually kind of hear you.
Thank you. I'm going to take some more questions. So we've got a hand up again in the middle. Oh, and one. Yeah, let's go there first, Becky, and then we'll go in the middle afterwards, Harvey, just here.
Oh, hi, my name's Daniel Elkleys. So I'm going to fess up to, I was the rooted patriot in the room, right? So yes, I think I'm patriotic. You read the description, you think, that's not me at all. And that's because all the questioning is all about immigration versus everything else. And what we have managed to alight upon is, in our politics in the past, blue and red was a very large coalition of lots of different groups of the population. And now where we are is we're picking one issue and trying to define everything based on that one issue when there are lots of issues. And the problem with that one issue, and this is where Samira I think is spot on, is that one issue is actually all about what do we feel like in our lives and what's it like to live in the place we do. And the southeast of England is totally different to much of the rest of the country, which is what I saw as Chief Exec of NHS providers, where you go to all these town centres that have nothing in them and people feeling pretty dismal and haven't got jobs, can't see how their kids get jobs. And the bit that then I think you have to reflect back to all of us is, we're sitting on a total goldmine of how to change all of that, called the NHS. It's the biggest employer, it's the biggest determinant.
So Daniel, do you have a question?
Yes, so the question becomes, how do you use what we as a collectively all think in this room to do something really different to change the rest of society? Because if we don't, the thing we most value, the NHS, is going to wither away because it isn't doing what people want, and they're going to go to extremes.
That is a big question.
Right.
Thank you. I'm going to also take one in the middle, and then I think we won't have time for further questions, so I'll come to you for your thoughts on those.
Thank you. Answer Fazar, Director of Public Health at Oxfordshire, also a member of the Association of Directors of Public Health Board. Just a simple question.
Thank you.
In terms of utilising the community leaders that we talked about, I think that's really vital in actually tackling polarisation, misinformation and disinformation. I think we touch around the surface on that, and you gave some really good examples, Samira, around how you utilise the libraries that Chris talked about, community leaders from Somalian communities and so on. How do we actually embed that at scale in our health and care system? Because I think if we do that at scale, and we will really be able to not only win trust, but I think we will be able to shift that power dynamics across. But I'm more interested in the mechanism of actually enabling that to happen. I've tried that with the communities in our work, but there is those barriers to get that power dynamics across to enable that to happen at scale, which I think will help to tackle polarisation, misinformation, and a really ownership around looking after your own health and care.
Great, thank you. So we've got two quite big questions. You said it was a small one, it's quite a big one. So Daniel's about kind of how what we do with the gap between this room and the population, and what that reflects quite existentially on the NHS in particular, and then one about communities and harnessing some of the brilliant stuff that we can actually see is happening in communities to tackle this. Who wants to go first?
I can
You
go
look
briefly,
like you want to go
yeah, because
first,
I think I'm very interested to hear Samira as well. I think actually just a common thread actually across both questions, and building actually on what Samira was saying in answer to the last question about community, it's this idea, I don't know how many people are familiar with the idea of contact theory, but it's one of the most powerful forces that there is to building connection and finding common ground between people who disagree with each other. Charles Duhigg's book, Super Communicators, has an excellent description of it, particularly looking at bridging gaps on.
So summarise it for those of us that haven't read that.
I will, yeah, gun rights in the US.
Yeah.
But it essentially involves bringing people together to work on something who disagree about all sorts of things. But there are two factors that makes it work and brings out the common ground. And if you don't have these at play, it doesn't work. The first one is they've got to have a common purpose that's actually almost unrelated to the area of disagreement. So you get it a lot in things like sports teams, community groups, choirs, that kind of thing. So you're interacting with people on a human level where you're just interacting as humans. And the second thing is you've got to have parity of status. So you've got nobody in that group who has a higher status through authority, expertise, etc., than somebody else. You bring people together like that, you can find a heck of a lot of common ground. Now, I don't know how you do that in practice. That is not something I'm expert in. Samira will be much more expert in it. I think many of you will be. But I think it's something to hold a thought over. How can we create environments that do that?
Thanks, Mark. Samira, do you want to come in?
Yeah, so I mean, there is something about very briefly, just in terms of the NHS, and actually kind of they're the bridge between us in this room, and actually our frontline staff are the bridge between us and the community, and especially kind of the different segments, if you like. So if you look at our frontline staff, especially the kind of your bands 3s, 4s, 5s, and 6s, they tend to be of those communities and from those communities. Then how do we work with them, and how do we see our communities as part of our wider workforce? So I think we need to blur the boundaries between our NHS institutions and our local communities. Second, just in terms of actually working with communities, I mean, honestly, I mean, there's something about the way communities work. They're very relational, they're messy, they're complex. You know, you're going to say one thing and do something else. So whereas organizations are very much about programs and activities and outputs and outcomes. So you've got two different systems. So for me, the idea is how do we create the space that brings the two together? They're both very important. But if you want to create something that's sustainable and self-sustaining, it's about starting with conversations in community settings and then using all our programs and plans and tools and everything to hold as the scaffolding that holds and builds on those relationships. And honestly, there's some amazing, talk to Bob about connecting care for children and how actually kind of bringing people down to community level. You know, there's Jacob who can tell you about the work with communities. There's amazing community champions. There's work we're doing in West Hertfordshire around actually, you know, the first conversation with Macmillan, I think Joni's here, it's about actually kind of the first conversation was in a small church, just sitting and having coffee. But that actually kind of means I connect to you and you connect to me.
It's really interesting because it feels to me that a lot of what you're talking about is physical communities, people going to places together, and what you're talking about is these online communities.
Yeah, it's how one conversation I was having with people that were running the Born in Bradford study programme was how do they bring the trust that they've built up in the community in Bradford into online spaces. Are there ways of doing that? I mean, I don't know the answer to that, and I think that is an area that we should perhaps look at, but it changes so quickly and things iterate so quickly on social media, and that's one of the issues with studying obviously the large language models as well, is how quickly they iterate. But talking about, there was a really interesting documentary building on what both these guys were saying it was set in Australia where a load of climate activists went and spent time in the areas where they were still mining for coal. And obviously climate activists wanted the coal mines to shut down. The coal, people working around coal, it was their jobs, it was their livelihoods, and they were polar opposites, but they spent time together talking. And it's a fantastic documentary. It's actually on YouTube, I think. It was really, but it sort of made me think of that documentary when we're talking about sort of getting conversation.
Brilliant. We're almost out of time. The title of this session is Polarisation Bad for Our Health? Do you believe polarisation is harming health, or are there ways in which this more open and contested information environment is actually quite healthy? Mark?
I think it is, but you've got to remember that, mistrust can be healthy as well. You don't want blind trust. We don't want to be doing things that create blind trust, but we want to be depolarising, because I think that will lead to healthy trust and healthy mistrust.
Deb?
I think it depends totally what we mean about polarisation. I think that when it is incredibly toxic, I think that's bad for health, because people retreat from the debate, or people will either that or they'll pick a side. And, you know, as a reporter, it's easier to go in with a side because you've got a tribe, rather than kind of go, well, let's unpick the nuance, because then you get attacked by both sides, she says from experience. So, I think that can be unhealthy, but I think if we're talking about healthy scepticism and questioning, then I think we should obviously, particularly in online spaces, why is this person telling me this information? It doesn't have to be sort of cynicism, but I don't think that's harmful. So agree with
Thank you. Samira?
I think if it's not managed, if it's not done in a way that really kind of brings out the, if you like, some of the tensions and the discomfort. So tension and discomfort and disruption, positive disruption is great. I think as long as it is actually kind of created in a space where people feel safe in really sharing their genuine views and are able to be honest and actually kind of talk about those issues. Polarization can be a really good way. It can be the irritant that actually kind of pushes things forward. So,
Great. Well, a great discussion. Thanks to Sarah Reid for the Nuffield for help with putting the session together as well. Thanks to Bex and Chris for this morning's session. And thanks very much to my panel. And please thank them in the usual way.